It's hard enough to eat right and exercise under the best of circumstances. But during a pandemic, it's a whole lot harder. And yet, there's a link between body fat, blood sugar, hormones, and the immune system, making it more important than ever to stay healthy during a global pandemic. This week, I spoke with endocrinologist Harold Bays, where we discussed the problem of obesity and the challenges of working with obese and diabetic patients to help manage their weight and stay healthy. Dr. Bays is the director of the Louisville Metabolic and Atherosclerosis Research Center, as well as an expert in obesity and lipid medicine. And he has some great insights for both clinicians and patients alike. Welcome, Dr. Bays. Thank you so much for taking the time to be here with me.
Thank you for having me. So it's been an interesting time, and I'm going to be interested in what you have to talk about.
Well, I mean, we know already that, we're a country that has an obesity epidemic, and it's obviously very important for people to maintain their healthy weight, and weight loss is a certainly large issue for practitioners, especially in endocrinology, who are working with patients who may have, a lot of weight gain or obesity. But in the context of COVID-19, we're seeing that that's actually even more important than ever. I don't know if you can speak.
Right. I mean, I think you nailed it right there. I think that's exactly right. There are just an enormous number of reasons why it is that having the obesity increases your risk for infection, but also increases the risk for a poorer outcome. And those reasons I think some of these can be pretty obvious, maybe others not so obvious, but when a person has obesity, they often have a decrease in what we call innate or acquired immunity. So they have increased susceptibility to infections, such as, say, for example, like flu and such. And so therefore it's of no surprise when we now look back and we look at the people who are getting most infected and are having the poorer outcomes, obesity's got to be near the top of the list of risk factors.
What do we know about, I don't mean to interrupt, but what do we know about this relationship between our immunity and our weight? Like, what's going on there? Like, do we have a clear understanding yet, or are we just still at the point where we have some ideas?
It's a little both. I think there's some things we do understand pretty clearly, but then there are other things. For example, the COVID-19 is a new entity, so we're still trying to figure that out. So that's fair to say that. But what I would also say is that there are certain sort of barriers and such that are adversely affected with the obesity. But the other thing that I would say is, why is it that people, when they gain body fat, develop the diabetes and the high blood pressure and the dyslipidemia? Why is that? Well, one of the reasons is because when your fat cells become too big, or when your adipose tissue expands too much, then you get what we call sick fat, or the adiposopathy, the pathos of adipose tissue. And when that happens, you not only get endocrinopathies, which contribute to the diabetes and the hypertension and the dyslipidemia, but you also get immunopathies. So you have a pro-inflammatory state. I mean, a lot of your folks out there probably know if a person has the central obesity, that their C-reactive protein is going to be elevated, for example. We know this. And it is because of that pro-inflammatory response that contributes to these other common metabolic diseases we find. And so you can only imagine that if at the same time you have diminished acquired and innate immunity, so you're susceptible to infection, but then once you get it, you have this pro-inflammatory response. Well, that's not good. That's a bad combination. And then you throw on top of that the fact that many of the folks with the obesity are going to have problems with breathing anyway. Maybe they have day or nighttime hypoxia, sleep apnea, impaired expiratory volume and such. You put all those things together, then all it takes is a little bit of an upper respiratory tract infection or a viral upper respiratory tract infection, and it's not a good situation.
So we've been hearing a lot in the news about the cytokine storm that happens in a
Yeah.
lot of these patients. So it sounds like what you're saying is that, you know, a patient who has obesity already is predisposed to having that sort of cytokine storm. Their body is very pro-inflammatory already and kind of at that tipping point of ready to go. So for them, this is an even more dangerous situation.
Well, that's the theory. As I said, obviously we're very early in trying to figure this out. But if you were to take the lessons we've learned from flu and other types of things, then I think that's exactly right. I think you summed it up very well. The only thing I would add is even if you didn't have this profound pro-inflammatory response, the fact that patients with obesity already have compromised lung function to start with, and maybe they again have day or nighttime hypoxia, you throw another severe upper respiratory tract infection on top of that, again, it's just not a good situation.
So what do we do? I mean, I'm sure that's the $1 million question, but I mean, for patients who already are overweight or obese, it's not necessarily something that you can just solve overnight, right? So, not to mention the fact that a lot of people now are in situations in which it's harder than ever to exercise, to eat right. Like we're all locked at home. Like things, that support networks that we might normally have had are kind of evaporating for a lot of people. So what do you suggest, and what are you telling your patients?
Right, and I think again, I think you spelled it out exactly right. So it was already a tough situation before. Now it's even a tougher situation. So I think there's several strategies. One would be is, you know, when this is all over, I hope the relative ease in which we were able to dedicate trillions of dollars to the COVID-19 pandemic, I hope we're going to look at that and say, you know, maybe we ought to apply the same sort of national priority to the obesity epidemic. Okay, make that a priority so that going forward, maybe things like this won't be as tough. So that's from the global standpoint. From the individual standpoint, I think if I had to pick the single biggest thing that I believe to be most important would be for people with the overweight or with the obesity to be aware of the fact that when there is this COVID epidemic, or pandemic, whether they be infected or just worried about being infected, that mental stress alone, or that being stay at home alone, or all of these types of things, people need to understand that there's going to be a potential connection between that and the worsening, not just of the obesity, but of its complications of the diabetes, hypertension, and dyslipidemia, and even heart disease. So I think the immediate thing that needs to happen is people need to understand what is going on with their bodies and be attuned to that.
Hmm. So more body awareness then of like how they feel.
Right. I mean, if you're let's just say, I mean, we know this to be true. If you're stressing out about COVID-19 and you're really worried about it, then again, maybe you're not you're not making as good a judgments as to what sort of things you might be eating around the house. Maybe you might go for comfort foods.
Mm.
So one of the practical things you can do is whether you go shopping yourself or whether you're ordering, a lot of people order and have their groceries delivered, is you might want to look over your list and check it twice, right? You might want to have a friend or family member check what it is that you're writing down, because obviously if it's in the house, you're more likely to eat it than if it's not in the house. So check that list. Make sure that these are healthful foods that you have in the house. And what you really want to do is to avoid ordering or going shopping when you're hungry. Mm. And now you start ordering all this comfort food and such. And I mean, look, I understand the temptation to say, look, I have so much going on in my life right now. I don't have time to worry about whether or not the food I have in the house is healthful or not. I don't, that's just the last thing on my mind. I really can't deal with that right now, but you have to, right? You have to. So Don't be ordering your groceries. Don't go shopping for your groceries while you're stressed and you're hungry and such. And then, as I said, maybe have somebody, maybe you should be checking over the list or have other people check over the list. And at minimum, try to eat healthful foods. And I think most people know what those are. But if you got them in the house, you're probably going to eat them if they're in the house. And if you don't have them in the house, then they're not available to be eaten.
Gotcha. What advice do you have? I mean, a lot of times there's some psychology, I guess, in like sort of, talking to patients to really get good compliance, I guess, if you will, get them to motivate them to really make some of these changes. Do you have advice for your colleagues who are, struggling with like, how to best help their patients?
Well, sure. We're in an age now where, look, there's nothing, I'm not going to say that the COVID-19, I would never say that there's going to be net positives out of this. This is horrible, and that's the end of the story. There is no discussion, okay? But to the extent that we can take some positive things from this, I think we should. And what I hope will be a positive thing is this advancement into telemedicine. All right, my hope is that that's going to really take off now, because I think there's just so much that you can do when you're spending your time educating patients, as opposed to doing certain procedures that maybe doesn't really benefit the patients, but you got to do the procedures because that's how you fulfill how the coding and how you get paid and that kind of stuff. How about we focus on what's best interest of the patient? Okay, so if the focus is on what's in the best interest of the patient, then if you start off with saying, okay, how's this stress working out for you here? Just start up. That's just right from the get-go, and try to think of good news to give folks. Give them hope. I think hope is underappreciated. Give them a prescription of hope. Then what you do is you do the same sort of techniques that you probably should have been doing in your clinical practice, which is record keeping. So you asked me what are some practical things that people can do. One of the most practical things that people can do is write down every single thing they eat and drink except for water. That alone, I have found, can make a profound difference. If people write down what it is that they eat and drink, going to make a big difference. And the same thing that has to do with physical activity. I get it. A lot of people, some people, not, they can't just leave the house. They can't even go to a park or whatever. I mean, that's not everywhere, but it's some places. Find out where it is you can go, what it is you can do. And people say, well, what is the best exercise for me to do now or after this is over? And my answer is always the same. It's whatever you will do, right? Whatever is safe and has a reasonable amount of caloric expenditure, at least relative to what your health is, that's the best exercise. Something for which you would be adherent, something that you will do. And yet again, record keeping. Keep a record of it. If you have we all have our wearable technologies. Yeah, there we go. See, we're all that way. Keep a record of it. Set goals per day and make sure you achieve at least those goals. And I think if you write down every single thing you eat and drink, except for water, and if you have a record or wearable technology that keeps a record of if something as simple as steps per day, I think that's an awful good start.
One of the things I think that wearable technology has done is be very helpful about aggregating the little bits of exercise that we do. I think sometimes maybe there might be a misconception, and perhaps you can let me know whether you agree that, exercise has to be this thing that we do like for an hour every day and we're sweating and it's hard and like it's terrible, but we have to push ourselves to do it. But I think one of the things that was sort of helpful to me, was learning that, hey, if I just park a little farther away in the parking lot and walk, that extra few minutes of walking, or I don't know how many, few hundred steps that I get, if you do that a few times, it starts to add up. And I think maybe these, our Fitbits and Apple Watches, maybe taught us that a little bit, that we could sort of very slowly add a little bit of exercise, and that actually does count.
I couldn't agree more. I think that's exactly right. What matters is your total daily expenditure. That's what matters. Now, yes, preferably you'd be wanting to do all the things you mentioned, the non-exercise activity of thermogenesis, these types of things. You would like the NEAT, NEAT. That's what you would like to have people doing that, getting their steps in, and doing the physical exercise.
Right.
Okay, you would like people to do all that stuff, but not everybody can do everything. So do what you can do. What is the best physical activity program you can do? It's whatever you will do that achieves the goals that you set for yourself.
You did, when you were mentioning about the virtual visits and things like this, do you think that that was something that we've just undervalued a lot? I mean, it sounds like from other doctors I've spoke to as well, that when it comes to preventative medicine and things like obesity, right? Long-term chronic conditions, these virtual visits can be really helpful, especially in patients who might be more homebound and have more difficulty getting around. It could be very good for them to have these like small visits. Like how are you finding, did you already use them in your practice prior to this, and have you increased that?
Yeah, so the answer is yes and no. The issue here is, I think we need to go back to our prioritization of what is in the best interest of the patient, right? What is in the best interest of the patient? And I understand that there are people who've gamed the system and there are people that rip off Medicare, and I understand all of that stuff. But there's got to be a way that we can get back to doing what's in the best interest of the patient. And when I first started practicing medicine, I would say that 2 out of every 3 office visits that I would have, I would be at my desk, and then there would be my desk, and then the patient would be on the other side of the desk. And we would sit there for 15 minutes, and I would have all these educational documents, and I would have their laboratory, and we would just have a back and forth discussion. And when they would walk away, they'd say, "That's seeing a real doctor." They were so thrilled about that. But then they changed the rules, and they said, no, in order for you to code a visit, you have to document that, you did this certain physical exam, or you did this and you did that and you did the other thing. Many times there were procedures and such which meant absolutely nothing with regard to the health of the patient. Now, I'm not saying that if a person's got a cough or a cold or pneumonia, you shouldn't be listening to their lungs. I'm not saying that. But I'm saying in otherwise asymptomatic individuals, there should have been allowances for visits where what you're trying to do is what's in the best interest of the patient. And many times what's in the best interest of the patient isn't an extensive physical exam. It's giving them that essential education that they need in order to lead more healthy lives. And so going back to the point that you just made, I hope going forward that now, obviously you can't do physical exams if you're doing telemedicine, right? You can't do that. So my hope is that we will be able to expand upon that and go back to the way when I think we were able to take better care of patients. And I understand there are going to be people that are going to game the system, and it's going to be awful, and we're going to read how terrible it was that this person ripped off Medicare and whatever, and I get that. But at the same time, there's got to be an allowance to facilitate our ability to do what's in the best interest of the patient.
I think it would be interesting to see as time bears this out. You mentioned, oh, okay, people are so concerned about whether or not, allowing these visits is going to allow someone to game the system or
That's right.
rip off Medicare. But what if the potential benefits that we got in terms of recouped healthcare dollars by actually helping patients lose weight and be healthier and not have so many, long stays in the hospital because they're not managing their diabetes, or, any of the many things that can go wrong with someone who is, obese. If we can avoid all of that, I would think we save the same money potentially that we might lose in some of these other ways. So, I mean, to me,
that's right.
it would be very interesting to see.
I get that. It's just that you just know
Yeah.
that somebody's going to do some horrible thing. And then when somebody reports it, then and then everybody's going to say we're going to have to go back to the way we used to do things, even if it's inferior, because of these isolated people that are, you know, are doing inappropriate things. And that's just not the way I think that we ought to solve problems. That we shouldn't take away the good just because there's bad people. I don't think we should do that. And I'll just give you an example. How many times do we do when we do the physical exam? You always hear people say, you know, pupils equally reactive to light. Well, how many times are they not equally reactive to light in an asymptomatic person that you have seen for 20 years? Okay, like never.
No neurological like concerns whatsoever, right?
Oh yeah, they're normal cephalic. What does that mean? That means our head looks normal. I mean, that's ridiculous that we spend so much of our time on these things, and we do it because that's what's required for coding in order to get reimbursed for an office visit via Medicare, and therefore for all the other insurance companies. What if we were to take all that time and we were to say, okay, today we're going to talk about ultra processed foods. We're going to spend the next 15 minutes explaining to you the dangers of ultra processed food. Let's get that. Which is more important then? If you have a patient who has the obesity, the diabetes, the high blood pressure, dyslipidemia, and is at high cardiovascular disease risk, which is going to be of more benefit to that patient? Educating that patient about healthful nutrition, or determining whether or not that their eyes are equally reactive to light. You see where I'm going with this?
I totally see where you're going.
You know, and I'm not saying you should never do a physical exam. I think, yes, you absolutely should. But there ought to be an allowance for times where your sole focus is to do what I think we all know needs to be done, which is improved education with regard to nutrition and physical activity.
Yeah. It sounds like education is really something that you're passionate about.
Yeah, I think it's something everybody should be passionate about. I think if you talk to most obesity medicine specialists and such, so I'm a diplomate of obesity medicine as well as clinical lipidology, and I'm an endocrinologist, so there takes in the diabetes, throw that in there. And I do clinical, like I said, I do clinical lipidology and all those types of things. What is more important to convey to patients than education about nutrition and physical activity, and then throw in there things like, what about side effects of drugs they might be taking? Maybe you can spend more time talking about that. There are a lot of drugs that can worsen a person's body weight, or can worsen cardiovascular disease risk, or can worsen your lipid levels, or can worsen your diabetes, or can worsen your blood pressure. These are the types of things that too many times when you get to the end of the visit, you don't have time to talk about because you had to do all these things in order to meet coding standards.
Do you ever find that sometimes also patients just don't, think about something being important? They don't realize that maybe, a drug that they're on, they have forgotten to tell you about, they just started it, or that they were on it, but they stopped taking it, or they're not taking it the way they should and they know it, but they haven't admitted it. Or for example, nutraceuticals, right? Maybe they're taking certain supplements and that isn't getting discussed in the mix. I think that those are also, the types of things that maybe patients need a little bit more time and prodding to feel comfortable.
But just prodding, I mean, I like what you said before. You said, well, a lot of times patients, they're not sure that all that stuff's important. They're not sure nutrition's important. They're not sure physical activity is important. They're not sure their medications are important. They're not sure that talking to the clinician about supplements is important. You know why they don't think it's important? Because it rarely gets talked about, right? Because there's never enough time dedicated to that within the context of a clinic visit. So if a person comes in and they have diabetes, hypertension, and dyslipidemia, by the time you go through all the metrics of each of those conditions and whatever, and then as I said, you do all these other things that you're doing many times explicitly for the purpose of fulfilling coding requirements, then you don't have time. That your time is up and it's time to go. What if we had a new paradigm? I wonder if we had a paradigm where you said, look, our focus is not just to fulfill criteria in order to get reimbursed by Medicare or insurance companies. Our focus is on what is in the best interest of the patient. That's our focus today. And if that means you spend 15 minutes, as I said before, talking about ultra processed foods or saturated fats, or talk about, as you mentioned, how many steps should you get in per day? You know, what are the types of physical activities that are appropriate for that individual patient? What about their concomitant medications? Are they on these supplements? And if they are, why are they on these supplements? And are some of these supplements dangerous? Why don't we spend our time focused on those things? And I think, as you mentioned before, I think if we were to focus our medical encounters with patients solely on issues that are in the best interest of the patient, I think we can get a whole lot more done than what we're doing now.
I was wondering if you had any experience with any of these. There's some programs that some hospitals and clinics have developed that are kind of like group programs where people come in and, you know, they do a small workout class and they get maybe a nutritional lesson and, you know, maybe some stress management tips, positive thinking. Like there are a whole variety of sort of wellness like things that are designed to help people manage these kinds of like chronic conditions. I'm wondering if you have any experience with those and you know, how you feel they fit into these kinds of paradigms, and you know, whether or not that's also something we need to be maybe investing our money more in instead of, you know, I think if I recall, most of them were not necessarily covered by insurance. So it was the kind of thing where patients would have to pay themselves. But I don't know that that's true necessarily.
Yeah. So on a global standpoint, what I would say is that fits under the category of whatever it takes. Whatever it takes. Okay. There is no one way to do things when it comes with obesity, diabetes, high blood pressure, dyslipidemia, cardiovascular disease, and I put in cancer there as well. There isn't just one way. There's multiple ways. So if there's patients that respond better to a group setting than an individual setting, then that's the right thing to do. If there's a patient that says, I really don't go for the group thing, it's kind of intimidating to me, I have individual questions, I prefer that, then that's the exact right thing to do, right? So I say whatever it takes, individualize the approach. The other thing I would say is, to some extent, it can't just all, I mean, here I've been ranting about government reimbursement and all that kind of stuff, because that's what we deal with every day. But look, at some point, it also does come down to the patient. And if the patient does have to spend some of their own money that's not necessarily reimbursed by insurance, but it's in their best medical interest to do that, then I can think of very few better investments for people to make. I mean, I guess the issue is, how do you know that you're going to a place that's reputable and whatever? And I mean, that's an entirely different conversation. But to the point I think where you're going is, what about people wherein that they have to pay their own money? And I would say, if it's a good investment, then spend the money. I think too many times people say, well, when it comes to my health, unless the insurance is going to pay for it, I'm not taking any money out of my pocket, right? So I'll buy these other things, but I'm not going to spend my money on my health unless it's reimbursed by insurance, because I've already got insurance and that ought to be enough. I think you got to throw away that kind of mentality. I think you got to say, I need to do what is necessary in order for me to improve my health, and maybe by extension improve the health of my family, my friends, and all those types of things. That is worth the investment. As I said, the only caveat would be, just be sure that when people do invest their money, they're not going out and going to some place that selling a bunch of supplements and such with unproven benefits and potential harm and whatever. Find reputable places to go. There are specialists in obesity medicine. That's a good place to go. You know, do your homework, figure out a good place to go, and then be willing to make that investment, to spend that money in your health, if that's what you need in order to live a better life.
Absolutely. I think that makes a lot of good sense. And I think the advice of, hopefully going to an obesity specialist that might have some, information on, hey, this is a really good program. We really recommend this program. We recommend these supplements. We know that they're, top quality, and, getting some feedback on what we need to do. And I guess, like you said, all of that is part of having the time to know your patient and talk to your patient about what is going to work for them and what their questions and concerns are. Right.
Right. You just have to be, because look, I mean, it's just my opinion. I'm a clinical researcher. I've been an investigator over 500 clinical trials, spanning about 30 years. I do a lot of publications. I'm on a lot of writing committees and such. And I think based upon that experience, a lot of times it just comes to prioritization. So for me, I know it's very easy just to go to the drugstore or go to the online and think if you just picked a supplement up, you're good to go. And that's all you need to do. I would put supplements way, way, way down on that list of priorities, because it's just really hard to find supplements where there's good hard data demonstrating that they're going to result in clinically meaningful improvements in whatever that you're trying to treat. Way at the top of the priority would be basic education about nutrition and the kinds of physical activities that are going to make a difference. That I would put like way at the top. And then something that you had mentioned before, somewhere there in the middle, I would also have a very detailed discussion about the concurrent medications that people are taking, and are they really what the patient needs to be on, or somehow did they get started by somebody and never got taken off, or do we have newer drugs now that are better than those? Or I got to tell you, sometimes when you have a discussion with patients about the medications that they're on, it's extraordinarily what you find. And sometimes just having a review of medications can make a huge difference in people's lives.
Last question, I guess, is when, with regards to those medications and certain things, there's definitely a certain percentage of people out there who have obesity or overweight, and feel like they've done everything. They do exercise, they do eat as healthy as they can, and nothing is seeming to work for them. How do we approach those patients and without making them feel like they're failures, like this is something that they're failing to do, when it's really them like fighting against their biology? And also, I mean, do you have a sense of what kind of what percentage of patients that is? I mean, can most people be helped like with a lot of changes in their lifestyle, and then we're just talking about a small subset, or is there a greater number that we know that really have sort of a metabolic dysfunction that isn't entirely within their control?
Well, first off, let's just be clear. Obesity is a disease. Okay, so let's just put that on the table. It's a disease, and it's a multifactorial disease. There's a lot of causes for obesity, and there's certainly a lot of physiology and pathophysiology that resists a person's ability to lose weight. The analogy I would make is it's like high and low blood sugars. If you have high blood sugars, a lot of times people don't even know it. They can have blood sugars in the 200 or 300 or 400 milligram per deciliter, not even really know it. Well, maybe they're going to the bathroom a little bit more, urinating, whatever, but generally didn't really know. On the other hand, you have a person get a low blood sugar, like 40 milligram per deciliter, 30 milligram per deciliter. Now they're hot and they're sweaty and they're shaky and they're nervous and all those types of things, about ready to go pass out. So what does that say? That says that that's an example of a body system wherein the body is very resistant to low blood sugar, not so resistant to high blood sugar. And I would make the same analogy to body weight. The body weight can go up and up and up, and people don't feel all that terribly bad, but you start to lose weight, your body is very resistant to a negative caloric balance, and it will do what it can to defend the weight that you were. So that's tough. You're fighting physiology. So So that is true. And yes, there are some very rare situations and rare conditions that can cause obesity, but again, very rare. But your question was, what do you do for the patients who say, look, I've tried everything, I've done draconian diets, I've done extraordinary amounts of physical activity, and I can just never lose any weight. And I remember when I first started, I would try to argue. I mean, I wouldn't argue, but I would try to discuss it with them, which a lot of times did lead to an argument, because I would say, well, maybe that's true, but let's talk about things that you can do. And then they're like, I've already done that. And again, it ended up going nowhere, and it was not productive. So what I learned is I don't even engage in that conversation now. I don't even, what I do is I'm like, I understand. I get what you're saying. You've really tried with the nutrition. You've really given it a go with the physical activity. So I'm making no judgments as to whether you've done that, whether you haven't done that, for how long that you've done that, or whatever. Instead, what I want to do is, let's have you keep a diet diary. This goes back to what we talked about before. I want you to write down every single thing you eat and drink except for water, and I want you to keep a track of all your physical activity. I'm not making any judgments whether you're doing it right, or you're doing it wrong, or you're doing it healthful, or you're doing it unhealthful. I'm not making any of those judgments. I just want to see the data. And it's remarkable, to me anyway, if you focus just on the data, how far you can get with helping people with adopting more favorable and more healthful nutrition and physical activity and these types of things. And so throw away the blame, throw away the accusations, throw away the condescension and those types of things, throw all that away. And instead, I find that if you focus on the data, that seems to work a lot better.
Make it less personal, I guess, if you will.
Right. Make it antiseptic, man. Make it science. And then you can go through it. Like I've noticed many times, if I have people keep a dietary diary, I find that 80 to 90% of what they're eating actually looks really healthful. It's just that there's like 10%, it's got to go. Mm-hmm. So if they're eating bacon and these types of things, I just say, look, you got to cut that out. That can't be on your list. Or maybe there's foods that they think are healthy. Like I remember there's certain fast foods where they have taco salads.
Oh God.
It's a salad. Yeah.
Or the salad dressings that are like 1 million calories, right?
Yeah. So you're eating 2 days worth of food there. And sometimes you find stuff, they're like, I didn't know, which is, again, goes back to what we were saying before. Simply by looking at the data and being able to take the time to educate people is going to do way more for people than to determine whether they have a normal looking head every single time they come in for a physical exam. That's my judgment.
All right. Well, thank you very much for that insightful advice. I appreciate you taking the time to talk with me today. And, I think it's been very informative for people.
All right. Thank you.
All right. Thank you very much.